Thank you so much. I'm so glad to be here, thank you. But I'm not normally speaking English, not at all, hardly, so please help me if I'm struggling to find a word. I know it in Norwegian, but it's very hard for me to find it sometimes in English. So just shout off if you can guess what I'm thinking of. I'm from the Norwegian Bladder Cancer Society, and we started in 2012, and I have been there since 2020. I will start with the story and how I became the CEO for this Norwegian Bladder Cancer Society. I grew up in a lovely place in Norway called Sykkylven, a small city. Outside the nearest city, bigger city is Ålesund. And Ålesund, that's a quite small city to be in Norway, but if you go to Norway, you have to go there. But I have been living in Oslo, and I have a lot of slides because I feel it's better, because then I know what's coming up and it's more like a movie, and then I can follow my brain and it's easier for me. This is Oslo, and that's where I was living when I started to feel bad. I felt, first I saw blood in urine in the summer, but I thought, okay, that's maybe normal. I was 54, and that's maybe normal then, that you should have some problems. So I didn't mention it much, but it didn't stop. I get more and more tired. I didn't see the doctor. I should wait, and I should see maybe it was stress, maybe it was something else. I get a lower back pain, and when I got very, very high blood pressure, like 180 something, and I couldn't sleep. I had headache every day. I went to work, and I was sitting there with this headache. And I felt like, no, I have to see my GP. And I went to him, and for several months, every week, because I said, I can't continue like this, because I'm not well. And I said, but maybe it's this, and maybe it's stress. But I said, no, it's something else. I can feel it's something else. They took CT, but I didn't find anything. They said, no, you're healthy and strong, it's stress. It took a long time before I got to, I met a pet, and the pet said, it's something wrong with your kidney, I can tell you. So you have to go to the doctor again and say that you want to have a CT with contrast. And so I got it, and I found a tumor, but it was in the pelvis, or a renal pelvis, and that's not so very common, and that's the reason why I had this terrible headache. They took it away, and I was very, very optimistic. I went home, but just after a few weeks, I started to feel worse again. It turned, and it had spread then to liver and lymph. And it was very aggressive. It grew like centimeters for 1 month. And it was full all over. So they said that, okay, we'll try with chemotherapy for as long as you can bear it or stand it. And if not, there's nothing more we can do. They say that you will have maybe 2-3 months left with this aggressives. So I went home to the lovely city you saw first, and I said, okay, I will die back home with my parents and my sisters. But something is wrong with this. But then I went home, and they said yes, because they said it was palliative care. I got it in Ålesund, where I was born, and I start to find that, okay, it's okay. I've had a good life, and this is it. But something suddenly changed again. I got a telephone call from a doctor in Oslo. He said that I've heard about your story. Maybe I can help you. You have got a clinical trial in Oslo. Maybe you can come back and you can take and join that one. And I was so happy. I was so sick as well that they took me in a wheelchair and got me to the airport, and I went down to Oslo again. And that gave me a new hope. That gave me a really, really big hope for the future again. Something could maybe do that I could live some more months or some more years maybe as well. And I had a fantastic follow-up. All the doctors, I had a personal number to the doctor so I could phone him. That's not normal in Oslo or in Norway, hardly in any country, I suppose. And I had these nurses. I went to the hospital every 14 days. I was sitting there like 7-8 hours to wait for my chemo, or not the chemo, but the immunotherapy, PD-L1. It was not then in the standard of care in Norway. They didn't have that, so it was just experimental. So I got it, and I think maybe 14 days after I started, I felt like, oh, this is it. Because I felt it was working. Maybe, of course, it was maybe my brain that wanted so much to survive. But I started to eat again, I started to exercise again, and I started to relax and more. I could sleep better. Everything started a very, very good wheel in a way. So I was, during the winter, I was again very, very optimistic. And I started to search, is it so? How come? Why didn't I know that blood in urine was so dangerous? And why didn't I go earlier so they could have stopped it? So I started to Google, as we do, and I found this Bladder Cancer Society in Norway, and I went into Facebook and I started to chat, and I was really, really active, as I am born, I think, active person. Oh, I'm a far ahead of schedule. So, but I started to ask them in the group, is it so? What's the problem? Why is it so few treatments for metastatic cancer? Why are you not talking about it? I thought it was only, okay, bladder cancer, that means stomia, nothing else. I didn't think that you could die from it. So, and I also started to think, was it so that I survived because I was connected to Oslo and was treated in Oslo? Yes, it was. My sister, she died 3 months earlier from cancer, and she was living in my village. And I thought, maybe my sister, if she also was living in Oslo, could have joined a clinical trial. And how is it? Why don't we know that? Why don't everyone, even if you're up in the north, you must know that there is a possibility. And the possibility must not be only in Oslo. It must be also in Tromsø, far up north, to join a trial. So when they, in this community, saw that I was very, very active and had a lot to say, the board contacted me and asked if I wanted to help them and to be their new executive manager. And I said, of course, thank you so much, because the system had then put me on a leave, for totally leave. So I was out of work, and I found it very, very interesting. So this is the board that we still have, except that we have changed this, unfortunately. We had to say thank you to our former leader, chair, Tore, but we have had a nice cooperation or collaboration for many years, but it's written in our statutes that we cannot have a chair more than 6 years, so then he had to quit. But we got a new woman in, and she's younger, and she is full of energy, and she is working in Microsoft, so I think that will be a big help for us. So, but when I came into this and start to work, I found that I have to have some focus areas because there was a lot of things to take to look at. And I saw the loneliness among the patients, lack of meeting places. It was lack of knowledge about bladder cancer in the population. That's not, we cannot live with that. Very little of the research findings went to bladder cancer. And that's also something, why should it be like that? Late access to new treatments. I think there's not only Norway, but Norway is one of the latest, I've heard. We are not willing to pay for treatments, but something is changing, I saw recently. And all this, what this was very, very interesting for me was that why is it? Why do we have different opportunities to participate in clinical trials? It shouldn't be depending on location, of course. So, but we were small, a small society with small resources and little money. So I think we have to cooperate with someone that can bring us up. So we found that we should join into the Norwegian Society, the Cancer Society in general, and they have 17 other patient organizations under their umbrella. And they're strong, and they are very, very clever. And I think also to be under them or to cooperate with them gives us also stronger credibility, yes, in a way. And the leader there, Secretary General Ingrid Stenstavold Ross, she said that closer collaboration means that we can put bladder cancer higher on the agenda. And that was, of course, very important for us. Johanna Ulveus, she got 8 million kroner, and also Professor Klungeland and Ogland, I saw that they also got money the same year. And it has been years and years since they got money. So, but we can say, so look at us, we are here, we need money. And they gave some money, and I saw in the newspaper yesterday that there was a breakthrough in this research. So, but we got money for research, we got also money for other things that we could do, and I said, okay, information is very, it's very important. So we start with webinars, seminars, we went around in the country and had meetings for the members. And they said, oh, this is the first time I ever have spoken to somebody else about my illness or about this cancer. So it was a very, very strong meeting with these people. And I saw that we needed more peers. And this is just a few of them. And we made them more visible in our website so that they could come in and find the names and the telephone number directly. And I also saw that these people that you saw, I think I contacted Rune and said, okay, I can see that you are, this research is very important, and you should know that it's very important for us, and we talk a little about it. And I asked him to come to us and tell more about the research for our members. And when you do so, I saw that, okay, he and I learned a lot. The members learned a lot. And we use him a lot for everything. He's an urologist as well, so he can tell us and about the news and especially about the research. So when they needed a patient expert, of course, they asked me because I have been in contact with them, and that's what I mean. That's so important. I think that's a little bit, we maybe think, oh, how important it is. to talk to people, be where the clever people are, like today, and be a part and try to be involved. I write, or we write about all this because he is doing, and what they are doing is fundamental research, is basic research, or RNA, and very difficult things. But I mean, even though I can't understand so very much of it, but I can translate it into a language that more people understand. So I can write about it in our magazines and in our website, and create and get more interest for basic research. Because without basic research, we wouldn't have clinical trials and we wouldn't have better medicines. So it's very important, and they say that it's so nice that you can come and lift us a little bit, because we are sitting there behind in our laboratories and think that is it worth it? And in such days, it's very, very nice that we are there to say, yes, come on. Another person that I met during this, when I'm all over, you can see Leo is also here in a picture. I met him in a conference in Oslo, and this wonderful professor, Åslaug Helland, she is she's trying to create centers all over Norway to, I will just take another picture. And the aim for the patients to be able to participate in clinical trials close as possible to their homes. And that's so important for me and for her. And to be a part of that again is so important, because I can learn so much about it and I can talk about it again. And when we talk about it, I think things happen more quickly. I have to read it because I put it in this morning. Yes, and they are also very, very into this, with patients' voice into the whole project. And I'm not alone there. I'm together with someone from Prostate and other organization. But what we learn is so important, and what we can give back to the audience. And I think also that to be present everywhere is important. To be there, to talk to people, talk to the right people. I've been invited many times to round tables. Okay, 2 minutes left. But I think it makes the road very, very, what do you call it? Shorter road up to the decision makers. What I saw was that there were so many researchers, they stopped researching on bladder cancer because it was more interesting with prostate cancer. And I think you've seen it in all the countries. So I said, okay, what can we do? Yes, we started to have seminars where we took all the best researchers in Norway that were researching on, had studies on bladder cancer, and made it as a yearly tradition to invite the best ones. And now they say, oh, I will come to you next year. So we can say thank you to them as well and say it's important. Your work is so important for us. Okay, my time is running out, but they were talking about this European Beating Cancer Plan. It's huge. It's 4 billion euro in it. So Norway wanted to join, and this EU Net CCC, Comprehensive Cancer Centers all over. They want to harmonize and have in each 31 country shall have the best cancer care in Europe. And that's fantastic. Then you don't have to go to Switzerland or to Germany to have to find the best treatments. You can have it, and you shall know that you have it in your own country. This is in 2021, it will be everything upstanding. I'm in 2 different work groups there, and they need more patient experts. And it's important that we are there. So if you're interested, please let me know. Okay, summary, patient participation and involvement, I can see that is so, so important. We are, of course, the patient voice, but we can make sure and make research more relevant and contribute to greater confidence in the research results. And that's not a sentence, that's very, very, I can see it so clearly that we are, because we are training the audience or the members to know what we are talking about, and they have more trust in us than in others maybe. We can gain more knowledge about cancer. I can do, and I can spread it. And the synergy effect is very, very, very strong. I see I missed out one, but I think that's it. I will just say thank you for listening. Thank you that I could come here, and good luck with your work. Thank you.
Anita. So would like to invite next Alessandro Boni. There you are. Alessandro is a board member of Associazione PaLiNuRo, right, in Italy, and also our board member of the World Bladder Cancer Patient Coalition. So I will just start this so you know. Yes. There you go. Okay. You can use this one.
Okay, good morning. Excuse me if I read my speeches for facilitate this speech and to facilitate your comprehension, I hope. I thank you for giving me the opportunity to share my story, the story of hundreds of thousands of people who have been diagnosed with bladder cancer. My name is Alessandro Boni. I am 69 years old. I live in Florence, Italy. And as you know, I've recently become part of the coalition, and I am a volunteer and advocate for Italian Patient Association PaLiNuRo. Chapter 1, the discovery. My appointment with bladder cancer dates back to May 2018, 7 years ago. But when and how did it start? You know that a powerful signal of this cancer is blood in your urine, but this didn't happen to me. I discovered my bladder cancer during a routine prostate checkup, during a prostate scan. I would like to emphasize this point because it would be useful for men no longer young. Please remember, a routine prostate checkup can be important not only for prostate but also for bladder cancer. So, in that faraway May 2018, without any other symptoms, an object in my bladder of 3 centimeters was found. What could it be? At the time, I knew nothing about bladder cancer. Then, quickly, I discovered, through my urologist, a particular useful and unpleasant medical test, the cystoscopy. Until that moment, I knew nothing about catheters and so on. Then, trusting and fearing, I experienced this invasive test. On screen, during the cystoscopy, I could see that in bladder, something like a little tree was growing. What is this? I asked. And the doctor answered me, oh, it's a little tumor, but don't worry, it's so little and we can eradicate it quite easily. A little tumor, maybe little, but a tumor. My God, I wasn't brave enough in that case to ask something else. In the year 2018, like the majority of people, I searched for something about bladder cancer on Google, and I discovered an universe. There was many articles by hospitals, clinicians, many tests written in medical jargon, and inevitably many miraculous drugs. At that time, AI hadn't caught on much, so I left these frantic searches with some approximate ideas about bladder cancer, and still a lot of confusion and fear. In any case, with this first medical diagnosis in my head, very upset, I told my wife what's happened. It's very important to have a caregiver. Wife, husband, friend, brother, sister, mother, son, daughter, to talk with and to receive from help and support. Then the doctor, after the cystoscopy, also said that I should have a TURBT. TURBT, as you know, is an acronym from transurethral resection of bladder tumor. In practice, it's an operation where, always through a catheter in the bladder, the tumor mass is removed from it. I had this operation in a private clinic in Florence and not in a public hospital. I made this choice for personal reasons, because at that time I worked for a public body and I had a private health insurance paid by my employer. After TURBT, as you know, the patient has to wait for the result of histological exam of the part of the tumor and the bladder muscle removed. For me, the histological exam revealed the diagnosis TAG3, that stands for a non-infiltrating tumor. Patients soon have to learn the medical jargon. At that time, I learned that the tumor was inside the bladder, and so I had to have intravesical therapy. So, trusting the urologists, I underwent the first cycle of 6 instillations of BCG. BCG stands for Calmette-Guérin bacillus, and as I learned some times later, it's a tuberculosis bacillus itself. I found later that BCG often gives severe side effects, and sometimes some people cannot tolerate it. But luckily, I endured the first 6 instillations without any problem. Chapter 2, the relapse. In September 2018, I had the first Euroscan checkup after the first cycle of BCG. But unfortunately, already where the tumor had been, something had formed. So in October 2018, I underwent another TURBT, this time in a public hospital in Florence. And they found that I had another tumor of 1 centimeter. The histological result of the exam this time was T2G3. Practically, as the doctor told me, the new tumor still was high grade and therefore dangerous, but this time he had invaded the muscular layer. No alternative to cystectomy were offered to me, although I later learned that a few do exist. Cystectomy means that according to medical guidelines and what the doctors told me, my bladder would be removed and maybe a new one would be rebuilt, since doctor says I would have tolerated the surgery. Chapter 3, the importance of the second opinion. Very upset, in agreement with my wife who helped me to maintain a cool head, I decided to get a second opinion. Dr. Google, him again, pointed out, among others possible good urologists, a urologist at the European Oncological Institute in Milan. He seemed to me a good expert, and he was and is a university professor at the Milan University. In Milan, the doctor wanted to repeat the histological exam. And this new one with the same bladder material, and gave me another result, T1G3, very different from the Florentine one. But this doctor wanted also to perform a third TURBT to be more certain of the diagnosis in early December 2018, which would establish more clearly whether there was or was not an invasion of the muscular tissue. Well, after this third TURBT in a year, the outcome was the confirmation of T1G3. Therefore, the cystectomy option no longer became necessary, and I had to have BCG therapy again. I could breathe again. I started BCG therapy in Milan once more, starting with 6 instillations again in January 2019, and then at 3-monthly intervals, another 3 weekly instillations interspersed with urinary cytologies, cystoscopies, EuroCT, and Euroscans. In any case, I finished the BCG therapy in March 2021, and I had the last checkup last December, when my bladder was found clean. Chapter 4, the end. I will have the next cystoscopy in November 2025, and at that point, my specialist will tell me how to go forward. But now I'm sure that I will continue the monitoring. When, how, and often, I don't know, because the dangers of this disease and the possibility of relapse, even if with low probability, will be with me for the rest of my life. But will I ever be cured? I'm curious what the medical guidelines indicate for patients with non-muscular invasive with 5, 10 years and over without relapses regarding their follow-ups. I would like to share with you what I learned from my experience. And I could be summarized this in 7 key phrases for my advocacy. The first one is the importance of a patient association. In my story, I was lucky because while I was feeling confused and looking for information, I came across an association, PaLiNuRo, which grouped together patients suffering BCG. This was very important for me. It meant that I was not alone, and I found people who had gone what I had gone through, whose experiences I could listen to, with whom to activate a network of positive relationships between patients and doctors. We never stop saying how important the role of patient association is in this field, especially for patients who meet this disease for the first time. Second, the importance, when needed, of a second opinion. At the beginning, I found myself in a critical situation. In my case, in October 2018, after the tumor's relapse, the decisions to have a cystectomy or not pushed me to search for another qualified opinion before going ahead. Thanks to this decision, I was able to save my bladder. An incorrect pathological analysis would have led me down another path, and now my story would be different. In PaLiNuRo, we support, above all in cases of important decisions, such as cystectomy or BCG failure, the patient's request for a second opinion, we are connected with the main national urological centers in Italy and with medical teams to promote a second opinion, strengthening the first opinion or offering a new perspective to the patient's choice, including trials on new therapies. The third lesson is the importance of correct and complete information about bladder cancer. For me, as happened to most cancer patients, the first reaction to the first diagnosis was surprise. But immediately after, I needed more and precise information about bladder cancer. Not always can we find it in hospitals and clinicians. Many of our searches on Google or questions to EI could be avoided or oriented with good medical advice, because without an adequate preparation, there could be a real risk to taking wrong decisions. In this sense, as PaLiNuRo, we have launched awareness campaigns of bladder cancer, started collaborations with the main Italian urological associations, and produce information materials, fact sheets, brochures for each state of this disease, from non-muscular invasive bladder cancer to cystectomy, from breaker packaging to BCG and mitomycin, to a booklet with the main medical terms. Our website is constantly updated with the main news in the field of bladder cancer and suitable for research on terminology and therapeutic practices. 4, the importance of finding quality, competence, humanity in clinicians and hospitals. The information and support that medical personnel give us is sometimes sparse and superficial. Maybe they are too worried about not generating greater anxiety. I think that working together, we can improve the relationship between doctors and patients. Correct communication is part of the treatment. This is the right way. In 2022, as PaLiNuRo, we launched an app that aims to allow patients to express their own assessment. The project is named UroH Advisor, or Urological Hospital Advisor, and the starting point was given to us by web platform on the restaurant experience, hospitality, and location, such as TripAdvisor. Our intention was and is to improve the wealth of experience in the treatment of bladder cancer by patients and caregivers, to guide people like them to choose the most competent, effective, and humane hospital for the treatment of the disease. Another of the most important functions of this app is information that helps the choice of the best hospitals close to home. For each hospital, we have also prepared information relating to the trials, the number of cystectomies performed, and the possibility of televisits and second opinions. 5, the heavy burden of the cost for bladder cancer patients. Many patients, and my experience, reveal that after the diagnosis of bladder cancer, we have to face the burden of the costs for medical consultations, therapies, surgery, follow-ups. This has a strong impact on family budgets. In countries where a public health system and where it works, generally the costs don't fall on the patients. While in other nations where there isn't a free public health system, the bladder cancer diagnosis and all that follows could be a big financial burden. How can we help? In Italy, the National Health Service is free. But for complex and often urgent operations such as a radical cystectomy or such as some particular therapies and follow-ups, the main problems are the waiting list. So often patients have to go to other regions and to go to hospital where waiting lists are not long, or go to private clinics where these services are ready and available, but where they were very expensive. As PaLiNuRo, we have realistically of acting on two fronts: reducing the costs for the second opinion with the use of telemedicine and web consultations in some Italian hospitals, and collaborating with INPS, the Italian social security institutions that deals with paid work permits, assignment of disability degrees, and disability checks or benefit. We are trying with INPS to develop common guidelines to extend these benefits to our patients. This is a work in progress. The sixth point is the impact on your psychological state after the BCG diagnosis. We mustn't forget that the news that you have cancer for some people can cause depression and anxiety. And this psychological situation can be an obstacle that could counteract the correct decisions and clinical compliance and distract from listening to the doctors and finding the proper clinical path. In Italy, for certain oncological pathologies like breast cancer, there is free psychological assistance for both patients and caregivers, but unfortunately not for patients who find themselves living with bladder cancer. As PaLiNuRo, we are trying in some hospitals where we are present with our volunteers to encourage a sort of agreement with psychologists for our patients, but certainly the problem must be brought to a regional or national level and to the same guidelines for bladder cancer that scientific societies of urology have. 7 and last. Sorry, but okay. 7, the role of caregivers, real help for patients. Sorry, but I couldn't have faced all this without the help of my wife. We can't emphasize how important caregivers are to overcome a critical state after the diagnosis, to deal with a long journey through therapies, checkups, expectation, relapses, side effects, and all you can find on this uncertain path. The role of caregiver is precious and essential, before and after therapies and surgery. PaLiNuRo, together with other patient associations, has successfully led the Tuscany region to have a specific law for caregivers. A few advantages and measures were recently introduced by Tuscany Regional Law 55 for family caregivers who assist a cohabiting family member who is not self-sufficient or with a certain degree of disability. PaLiNuRo, together with other patient associations, continue to fight to extend these facilities to other Italian regions. I hope that my experience could be useful for you, and I remain at your disposal for questions. Thank you.